This lesson is Biological Effects of Radiation, a 15-minute intermediate lesson in the Safety and Radiation Physics category. This is one of the most concept-heavy topics on the ARRT Registry, and it connects directly to why radiation protection standards exist, why error matters, and what happens when the limits are not respected. We cover how radiation damages cells, the radiosensitivity hierarchy, stochastic versus deterministic effects, carcinogenesis, acute radiation syndrome, local tissue effects, and the radiation units. 15 minutes. Radiation causes biological damage by ionizing critical molecules inside the cell. Two targets, DNA and water. Direct effect. The radiation directly strikes a critical target molecule, usually DNA. An ion pair is created within the molecule itself. Approximately 30% of biological damage is direct. This mechanism is more common with high-LET radiation, alpha particles, and neutrons, which deposit energy densely along their path. Indirect effect. The dominant mechanism for diagnostic X-rays. Radiation ionizes cellular water through a process called radiolysis. Ionized water produces free radicals, particularly the hydroxyl radical, written as OH with a dot. These highly reactive molecules then attack nearby DNA. Approximately 70% of biological damage is indirect. Oxygen dramatically enhances this effect. Oxygenated cells are more vulnerable. DNA is the primary biologically significant target. 4 types of DNA damage: single-strand breaks, SSB, double-strand breaks, DSB, base damage, and DNA cross-linking. Double-strand breaks are the most lethal. There is no intact complementary strand to use as a repair template, so repair is inaccurate and prone to mutation. Single-strand breaks. The intact strand serves as a template, usually repaired accurately within hours. Cells do repair radiation damage. Most sublethal damage is repaired. This is the rationale for fractionated radiotherapy. Unrepaired or misrepaired DNA leads to mutation, cell death, or malignant transformation. The law of Bergonie-Tribondeau, established in 1906, states, cells are most radiosensitive when they are rapidly dividing, undifferentiated, meaning primitive and unspecialized, and actively growing. The 3-column table on this slide organizes every clinically important tissue by radiosensitivity. Most sensitive, the red column. Lymphocytes, B and T cells. Bone marrow stem cells, erythroblasts. The male germ cells, spermatogonia. Ovarian follicle cells. Intestinal crypt cells. And embryonic and fetal cells. The most radiosensitive tissues in the human body. Intermediate, the amber column. Endothelial cells, growing cartilage, osteoblasts, GI mucosal epithelium, urinary bladder epithelium, and the lens of the eye. Least sensitive, the green column. Mature muscle cells. Mature neurons, postmitotic, do not divide. Mature red blood cells. Mature bone cells. Connective tissue. The pattern is clear. Cells that divide rapidly and remain undifferentiated are at the top. Cells that stopped dividing and became highly specialized are at the bottom. This single law explains the entire radiosensitivity hierarchy and is tested consistently on the ARRT. 2 fundamentally different categories of radiation effects. The distinction is one of the most important concepts in radiation biology. Stochastic effects. The word stochastic means random or probabilistic. With stochastic effects, the probability of the effect increases with dose, not the severity. There is no threshold. According to the LNT model, any dose carries some probability of causing a stochastic effect. If the effect occurs, its severity is independent of dose. Cancer from radiation is the same cancer whether it came from a low dose or a high dose. The 2 stochastic effects, radiation-induced cancer and genetic mutations. Latency periods range from months to decades. Deterministic effects. The word deterministic means predictable, cause, and effect. With deterministic effects, a threshold dose must be exceeded before any effect occurs. Below the threshold, no observable effect. above the threshold. The severity of the effect is proportional to dose. More dose above the threshold, worse effect. Examples: erythema, skin redness; epilation, hair loss; cataracts; sterility; acute radiation syndrome. Registry key fact: stochastic, increased dose increases probability. Deterministic, increased dose increases severity. Two completely different relationships. The line chart on this slide shows the linear no-threshold model, the LNT. The risk of cancer rises linearly from the origin, from zero dose, with no safe threshold. Every dose, no matter how small, carries some risk. This is the model that underlies all radiation protection standards worldwide. ARRT, as low as reasonably achievable, is derived directly from the LNT model. For dose-response model types: linear no threshold, LNT, risk proportional to dose. No safe dose, line passes through origin. Basis for all regulatory dose limits. Applies to stochastic effects. Linear threshold, risk linear, but only above a threshold. Some argue that deterministic effects are better modeled this way, and some argue that low-dose stochastic risk follows this pattern. Quadratic non-threshold. Risk increases as the square of dose, more relevant at high doses. The linear quadratic model combines both and is widely used in radiotherapy planning. In hormesis, controversial. The hypothesis that low doses may actually be beneficial by stimulating cellular repair mechanisms. This model is not accepted as the basis for radiation protection standards. It is tested as a concept on the ARRT, but should be recognized as controversial and clinically irrelevant. Two categories by who is affected: the irradiated individual themselves or their descendants. Somatic effects affect the irradiated individual. The word soma means body. These affect non-reproductive body cells. They cannot be passed to offspring. Somatic effects are divided into early, occurring within days or weeks, and late, occurring months to decades later. Early somatic, acute radiation syndrome, skin burns. Late somatic, cancer, cataracts, fibrosis. Genetic or hereditary effects affect the descendants of the irradiated individual. They result from damage to germ cells, sperm, or ova, and mutations passed to future generations. Genetic effects are stochastic, no threshold. Most radiation-induced mutations are recessive. They may not become apparent for multiple generations. Important: no direct human evidence of heritable radiation effects has been observed in the Japanese atomic bomb survivor cohort, despite decades of follow-up. This does not mean the risk is zero. It means the effect is smaller than originally feared. Embryo and fetal effects. The most radiosensitive time in human life. 3 developmental windows. Pre-implantation, 0 to 2 weeks, all or nothing. The embryo either fails to implant and is reabsorbed or survives normally. Organogenesis, weeks 2 through 7. The highest risk window for malformations. Each organ system has a critical period of formation during this phase. The fetal period, 8 weeks onward. CNS development continues. Microcephaly and intellectual disability are the primary risks at this stage. The dose threshold for malformations is approximately 50 milligray, 5 rad below 50 milligray. The risk of malformation is not measurably increased above the background rate of 3% in all pregnancies. The NRC occupational limit for a declared pregnant worker is 5 millisieverts for the entire gestation. 5 number concepts on radiation carcinogenesis. Mechanism. Radiation causes a DNA mutation in a somatic cell. If that mutation affects oncogenes or tumor suppressor genes and escapes both cellular repair and immune surveillance, the cell may undergo malignant transformation. This is a multi-step process: initiation, promotion, progression. Radiation acts primarily as an initiator. Latency period. Time between exposure and clinically evident cancer. Leukemia. The shortest latency, 2 to 5 years after exposure. Solid tumors, thyroid, breast, lung, 10 to 40 years latency. This long latency makes it impossible to attribute any individual cancer to radiation with certainty. Most radiosensitive tissues for cancer induction. Highest risk: bone marrow, leukemia, thyroid, especially in children, breast, and lung. Intermediate: colon, bladder, ovary, stomach. Lower risk: skin, bone, muscle, nerve. The thyroid in children is particularly sensitive. The Chernobyl nuclear accident produced a large, well-documented epidemic of thyroid cancer in children and adolescents who received radioactive iodine-131 fallout. Evidence base: the Japanese atomic bomb survivor study is the largest and most important radiation risk data source. The Radiologic Technologist Cohort study showed dose-dependent cancer risk from occupational diagnostic radiation exposure. Uranium miners, lung cancer from radon, radium dial painters, bone osteosarcoma from internally deposited radium-226. Pediatric CT, retrospective studies demonstrating leukemia risk. Acute radiation syndrome, ARRT, result from whole-body or large-field exposure to high doses of penetrating radiation received in a short time. This does not occur from diagnostic imaging. The doses in ARRT are orders of magnitude above any diagnostic procedure. It is tested conceptually on the ARRT. For syndromes, in order of increasing dose: 0.5 to 1 gray, prodromal symptoms: nausea, vomiting, diarrhea within hours of exposure, fatigue, and anorexia. These symptoms may subside, a latent period of apparent recovery, before the next syndrome begins. 1 to 10 gray, hematopoietic syndrome. The most common survivable ARRT: bone marrow suppression, depletion of lymphocytes, neutrophils, and platelets, leukopenia, and thrombocytopenia. Peak marrow depression at 30 days. Death from infection and hemorrhage within 60 days without treatment. LD 50/60. The dose lethal to 50% of an exposed population within 60 days is 3 to 4 gray without treatment. 10 to 50 gray, gastrointestinal syndrome. Destruction of the intestinal crypt cells strips the mucosal lining. Severe diarrhea, dehydration, and sepsis from translocation of gut bacteria into the bloodstream. Death within 3 to 14 days. Uniformly fatal above 20 gray. Greater than 50 gray, neurovascular syndrome. Immediate incapacitation. Seizures, loss of consciousness, cardiovascular collapse. Death within hours to 3 days from cerebral edema and vascular damage. No treatment possible. Doses seen only in criticality accidents. 5 specific dose thresholds for local tissue reactions. The registry tests these numbers. Skin erythema. Threshold: approximately 2 gray. 2 phases. Early transient erythema within hours that fades, followed by main erythema at 2 to 4 weeks. Fluoroscopy is the diagnostic procedure most associated with radiation skin injury. Long procedures over the same skin field accumulate dose. Epilation, hair loss. Temporary epilation, 3 to 4 gray. Regrowth is expected. Permanent epilation, greater than 7 gray. Latency, 2 to 3 weeks post-exposure. Cataracts, posterior subcapsular cataracts, the classic radiation lens injury. Threshold, approximately 2 gray acute, recently lowered by ICRP in 2011 from the older value of 5 gray. Latency, months to years. This is why leaded glasses are recommended for fluoroscopy workers. Gonadal effects. Male, temporary sterility at 0.15 gray. 15 rad permanent sterility, 3.5 to 6 gray. Female, temporary infertility at 0.65 to 1.5 gray. Permanent sterility, premature menopause at 2 to 3 gray. These numbers justify gonadal shielding in reproductive age patients. Bone marrow, LD 50/60 is 3 to 4 gray without treatment. The absolute lymphocyte count drops within hours of whole body exposure. The most sensitive early biological dosimeter available, 6 modifying factors that change how much biological damage a given radiation dose produces. Oxygen enhancement ratio, OER. Oxygen dramatically enhances radiation damage through the indirect effect. Free radicals persist longer and cause more damage in the presence of oxygen. The OER for X-rays is approximately 2.5 to 3, meaning hypoxic cells require 2.5 to 3 times more dose to produce the same damage as oxygenated cells. Hypoxic tumor cores are more radioresistant, a significant clinical challenge in radiotherapy. Linear energy transfer, LET. The energy deposited per unit path length, measured in kiloelectronvolts per micrometer. Low LET, X-rays and gamma rays, sparse ionization, mostly indirect effect. High LET, alpha particles, neutrons, protons, dense ionization, more direct effect, less oxygen dependent, and more effective per unit dose. Relative biological effectiveness, RB. High LET radiation causes more damage per gray than low LET radiation. Dose rate effect. High dose rate means less time for cellular repair between ionization events, more damage. Low dose rate. Same total dose delivered slowly. Allows more repair, less damage. This principle underlies fractionated radiotherapy. Cell cycle. Cells are most sensitive during M phase, mitosis, and the G2/M boundary. Most resistant during late S phase, when DNA synthesis machinery and repair enzymes are most active. The order from most to least sensitive: M, G2, G1, S, radiosensitizers and radioprotectors. Radiosensitizers increase damage. Oxygen mimetics, some chemotherapy agents including cisplatin. Radioprotectors decrease damage, thiol compounds. Amifostine is the only FDA-approved radioprotector used in radiation therapy. Not relevant to diagnostic imaging doses. In fractionation and radiotherapy, the 4 R's: repair, repopulation, redistribution, reoxygenation. Fractionation exploits all 4 in favor of sparing normal tissue while killing tumor. Not relevant to diagnostic imaging, but conceptually tested. For radiation quantities, know all 4 cold. Absorbed dose. Traditional unit. Rad-SI unit. Gray, GY. Conversion. 1 gray equals 100 rad definition. Energy deposited per unit mass. 1 gray equals 1 joule per kilogram. Used for ARS and deterministic effects. The same absorbed dose in gray may have different biological effects depending on the type of radiation delivering it. Equivalent dose. Traditional unit. Rem. SI unit. Sievert. SV. Conversion. 1 sievert equals 100 rem. Calculated as absorbed dose multiplied by the radiation weighting factor, WR. The WR accounts for the different biological effectiveness of different radiation types. X-rays and gamma rays, WR equals 1. Protons, WR equals 2. Alpha particles, WR equals 20. Equivalent dose is used for occupational dose limits. Effective dose. Same units as equivalent dose, sieverts and rem. Calculated as equivalent dose multiplied by the tissue weighting factor, WT. The WT accounts for the different radiosensitivities of different tissues. Effective dose allows meaningful comparison of risk from different imaging procedures involving different body parts. A chest CT and an abdominal CT deliver different effective doses because different tissues with different WT values are irradiated. Exposure. Traditional unit. Roentgen, R. SI unit. Coulombs per kilogram. Definition. Ionization produced in air by X-rays or gamma rays. Applies only to air, not tissue. Used for equipment calibration and output measurements. Not a dose quantity. It measures the radiation field, not what the patient absorbs. The conversions for the exam. 1 gray equals 100 rad. 1 sievert equals 100 rem. These 2 conversions are directly tested on the ARRT. 3 biological effects questions. These are registry-level clinical application questions, not just definitions. The answer is C, hematopoietic system, bone marrow suppression. At 3 gray, the patient is at the boundary of the hematopoietic syndrome range, 1 to 10 gray, and is at approximately the LD 50/60 without treatment. The bone marrow contains rapidly dividing, undifferentiated stem cells, the most radiosensitive cells per Bergonie- and Tribondeau H. Severe leukopenia and thrombocytopenia develop, with peak marrow depression at 30 days. The GI syndrome requires 10 gray or more. The neurovascular syndrome requires greater than 50 gray. The answer is B. Stochastic effects increase in probability with dose. Deterministic effects increase in severity above a threshold. This is the core distinction. Stochastic, no threshold. Any dose carries some probability. Severity is independent of dose. Deterministic, threshold exists, no effect below it. Above threshold, the severity is directly proportional to dose. More dose above the threshold equals worse erythema, worse ARS, faster cataract formation. Know this cold. It is tested every administration. The answer is B, the law of Bergonie- and Tribondeau H. This 1906 law states that cells are most radiosensitive when rapidly dividing, undifferentiated, and actively growing. Intestinal crypt cells and bone marrow stem cells satisfy all three criteria. They divide continuously and remain primitive. Mature muscle and nerve cells are postmitotic. They essentially never divide, making them the most radioresistant cells in the body. The inverse square law governs intensity with distance, not cellular sensitivity. The OER governs oxygen enhancement. The LNT governs dose probability relationships. Lesson complete. You cover direct and indirect radiation effects with the hydroxyl free radical mechanism and DNA strand break types. The law of Bergonie- and Tribondeau H with a complete radiosensitivity table, stochastic versus deterministic effects with a probability versus severity distinction, the LNT model and dose response curves, somatic and genetic effects with embryo and fetal dose thresholds, radiation carcinogenesis with latency and tissue sensitivity, acute radiation syndrome with all 4 dose ranges, local tissue dose threshold for skin, lens, and gonads, modifying factors including OER and LET, and the 4 radiation quantities with SI units and conversions. This is foundational radiobiology. It connects to every other safety and protection concept on the ARRT Registry.